Hello, how are you? My name is Winnie Barawa. Welcome to this session on chest tube drainage, what we commonly call chest tube. And in this session, we are going to explore more about the chest tube, how do we use it, the insertion indicators, and the contraindications when you're not supposed to insert a chest tube. We'll also explore the different types of chest tube. We'll look at the different sites of insertions, and then we explore the management and possible complications of chest tube management. And if you're new, I always encourage you to click on the subscribe button. Also, as you participate in this class, remember to leave us a comment. But more so, this channel focuses more on lectures, lessons, and expert interviews pertaining to healthcare. So be with me as we move. So by definition, a chest tube drainage is the insertion of a tube into the pleural space to evacuate air or fluid or any other substance that is occupying the pleural space. So the main agenda is to help the pleural space regain its negative pressure so that we can re-expand the lungs, which have either collapsed from mostly pleural effusion cases or pneumothorax. So here is an illustrative diagram, and we are saying we have two lungs, each located in the different pleural cavities. And on this lung here, there's accumulation of blood in the form of pleural effusion in the lungs in the space. And in this case, the chest tube targets such substances to drain them out into what we call the drainage container. So the chest tube insertion is done, or there are different reasons why you may want to insert a chest tube, and one of it is to allow drainage of the problem substance. And the problem substance could be fluids in form of pus, in form of blood, or generally any fluid that the system could produce based on the disease that the client has. Then the reason for inserting the chest tube can also be for the restoration of the normal interpleural pressure, which is very key for allowing adequate expansion and recoil of our lung during expiration and inspiration. And performance of chest tube is important also for permission in terms of expansion of the lungs in case they have collapsed due to different diseases and illnesses. And it's important that we do chest tube for the reasons of promoting adequate gaseous exchange. So in the instance of lung collapsation due to diseases like pneumothorax, for example, you will find that there is no proper gaseous exchange and the tissue perfusion in the system reduces. So as a result, this leads to poor metabolic processes in major organs like the liver, the kidneys, even in the digestive systems and so on. So to enable us regain all these tissue perfusions, it's important that we drain any substance that is occupying the pleural space to promote re-expansion of this lung and adequate gaseous exchange in the systems. So keeping on, there are instances where it's contraindicated for chest tube insertions, and these indicators are mainly three, and I'll mention the first one where we talk about coagulopathy or platelet dysfunctions. So in coagulopathy and platelet dysfunction, we're talking a case whereby the client suffers from abnormality in terms of coagulation and bleeding characteristics. And in this case, you find if someone has very low platelet levels, it means if you make a chest tube insertion, they may suffer from extreme bleeding cases. Or in another case, if a client also have coagulation issues and they have extreme blood clotting processes, if you have chest tube being inserted in such an area, this client can suffer the risk of too much clots that can also hinder the evacuation of the substances at the pneumothorax spaces. And the other contraindication is mesothelioma conditions. And by mesothelioma, we mean it's a rare form of cancer that develops from the protective lining that covers majority of the body internal organs, and one of their common sites is the pleura. So mesothelioma can also happen in the pleural spaces or in the pleural linings, and it can cause risks when it comes to insertion of this chest tube. Either possibly because it's a tumor. If you injure a tumor, most of the time it predisposes the patient to extreme hemorrhage, and it can take them through hemodynamic shocks. So in case of such indications, then do not insert a chest tube. Then the other bit is pure tuberculosis effusions or TB-related effusions. So in the TB status, it's advised that you also avoid chest tube insertions. One of the reasons for this is because TB has a very high infectious level and it can easily spread to other organs if tampered with unnecessarily. So what are the main indicators now when you want to insert a chest tube or indications? So remember the first slide we talked about reasons for inserting a chest tube, but in this level we're talking about the indications that are important for you to insert a chest tube. Most of we look at it in form of diseases. So the main indication is basically because you want to evacuate air or fluid from the pleural space, and in these cases you could be talking about diseases like pneumothorax, hemothorax, pneumohemothorax, pleural effusion cases, but also in another case you could be having pleural collections for the purpose of culture sensitivity or for the purpose of doing pleural fluid analysis. So in pleural fluid analysis, you could be performing collection of samples for lab examinations, or you might be doing thoracentesis for the purpose of eliminations. Additionally, chest tube is indicated for mechanically ventilated patients who have pneumothorax or hemothorax. So in mechanical ventilation for clients who have the pneumo or the hemothorax, it's therefore important that you can also go in for chest tube, that is to evacuate the fluid or to evacuate the air that the client could be uh, straining from. Then the other bit is diseases like respiratory distress or ventilator dependency that does not permit any case of thoracentesis in interventions. And so in such clients, you can also put them on chest tube. But the other bit is monitoring and going any air leak or blood loss. So the indicators for chest tube can vary from the reasons why you want to do it, but also it's advised to approach this from the aspect of which conditions are you looking at as you're inserting this chest tube. So when it comes to conditions, you look at pneumothorax, hemothorax, pneumohemothorax, pleural effusions, to other cases of mechanical ventilation, clients who do not allow easy thoracentesis, but also the agenda is to help us evacuate air or fluid from the pleural space and to help us also monitor the ongoing air leak or blood loss. So this area explores the sites for the chest tube insertions, and it's good that we know that the sites are different when you're talking about hemothorax or pneumothorax. So when you're looking at fluids, the site is a bit different, and when you're looking at air, the site is also different. So with fluids, the good example is hemothorax. So you're talking about fluid, blood accumulation in the pleural space. So in fluid, the chest tube is normally inserted between the fourth to the sixth intercostal space at the mid-axillary line. So in the evacuation of fluid, the line that is indicative here is the mid-axillary line, and so we shall insert the chest tube in between the fourth to the sixth intercostal space. However, when it comes to the pneumothorax cases, the tube is normally inserted in the second or the third intercostal space using the mid-clavicular line. So the target of the pneumothorax is normally the anterior chest, and so we use the mid-clavicular line. However, for pneumothorax, we don't target the anterior side, so we go to the laterally, and here we shall be using the mid-axillary line. So why the different locations? Why is one on the fifth to sixth and another is on the second to third? Well, looking at fluids are a bit heavy and they tend to settle on the lower sides of the lobes or on the lower sides of the pleural space, and so using fourth to sixth is actually the best location for us to evacuate these fluids. However, on the other side, air is a bit light in weight and so it tends mostly to float. And so in this case, to access this air easily using the second or third intercostal space is very best. So that's how you target the different. So when it comes to fluid, you target the very low ends, that is to access the fluid where they're settling. While when it comes to air, you target the upper spaces so that you can easily get the air that has occupied this different pleural space and get it out. So hemothorax, you go to the lower side, while pneumothorax, you use the upper side of the chest along the mid-clavicular lines. And exploring more for the sites for the chest tube insertion, there are different steps one has to follow in order to insert this chest tube. And the first step you told, this is a sterile procedure, and it's also an anesthetic procedure, meaning you need to use anesthesia, local anesthesia that is. So the first bit is you identify the site where you want to insert your chest tube, if it's either under the mid-axillary line or it's in mid-clavicular line. So you're supposed to make a 2 to 3 centimeter transverse incision mark. If you're talking about pneumothorax or hemothorax, so you will use the appropriate mid-costal space, and then you do the marking of the incision site. And then after that, you need to administer local anesthesia in the area where the insertion is to be made. So you make sure that you inject this all the way to the skin and the tissues. And then once this has successfully been done, you have marked the site, you have localized with anesthesia on the target site. The next bit is to get the thoracostomy tube or the insertion tube and be able to insert it to the area where you need to. Make sure you have inserted it all the way into the pleural space, and in it there's no any form of injury that is there. They ensure that the tube is not clamped, ensure the tube is not blocked. So once you've done that, then you need to suture it in space so that it doesn't get dislodged or move out. So you suture it into the skin and then you secure it with a tape. So in this diagram here, you can see how the postoperative view looks like. So the tube has been adequately inserted and it has used the required length. And in this, it has been secured with a tape onto the skin, but also there's a sutured area here of the tube into the skin so that it does not get dislodged out. Similarly, after successfully inserting it, after making the incision and inserting it into the pleural space, we are supposed to secure it using the gauzes first. So the gauzes are supposed to help us prevent further air entry into the space and also prevent it from cases like bleeding, but also the agenda is to ensure that the tube is well placed into the site. There's no any extra air entry and there's no risk for any form of infections. And then you tape it, that is, you get a tape to secure these gauzes into the skin so that it also doesn't come out easily. But as you can see, the tube is also secured with sutures. This is to simply ensure that it's properly located and it does not get to either go in or come out easily. And you need to observe the content that is coming out. So is it blood, is it air? By checking in the collection containers if you are talking about blood, or if you're looking at the bubbles, if the collection amounts are increasing or decreasing. So you want to check all that. But this is the final look that you will have at the chest tube insertion site. So the role as a healthcare provider will be more so to check on the any form of leakage, swelling and tenderness, infection cases around the site, and basically doing proper dressing using a septic technique. So in summary, you have like 4 steps, and the first step is to mark the incision site, localize with anesthesia the incision site, then insert the tube. And once you've inserted that tube, make sure you have sutured it in place, tape it, and then get to have a gauze so that you can now properly secure it to prevent any further air entries and to ensure that there is no unnecessary bleeding that is taking place. So this takes us into basic principles of chest tube management, and there are 3 principles that are very important. One of it is what we talk about the gravity. The second principle talks about positive pressure, and the third principle looks into sanctioning or sanction. So under gravity, it's said that the chest tube management is guided by gravity principle, in that the content are supposed to flow using gravity. And because of this rule, it's said that when you are under chest tube management, the chest tube should not be placed above the chest level. This is because if you do that, you will be moving against gravity and the content will not flow out. So because we are talking about gravity, it's said the content in the pleural space can easily flow from higher to lower levels. And so it is important that you allow the content to, or the system to be placed in a way that it's below the chest to promote more gravity to facilitate the contents to come out. The other principle is on the positive pressure. And in the positive pressure, this is the pressure that is created by either the air or the fluid when it is inside the pleural space, and this pressure allows it to push the content out so that it can flow into the collection point. So while the fluid is accumulating in this area, in the pleural space, or the air that is in this space, the more it accumulates, the more it increases the volume and expands. So when this happens is it leads to buildup of pressure, that is the pleural pressure, which now becomes higher than the atmospheric pressure. And because of this, it tends to push out the content to come out. And so that's when they can easily collect in the collection bottle for the chest tube. The other bit is the sanction. So when you talk about sanctioning, we are looking at the subatmospheric pressure that is reduced. So it promotes the air or the fluid to move out from the higher to lower pressure rapidly. So looking at this space again, where the content is accumulating, the content is filling up. So what happens is it creates a sanctioning effect in this place, and the content can basically come out and sanction out into the collection point. So the three principles working on the chest tube management is the gravity, the positive pressure, and the sanctioning. So these three basically allows us to maintain our chest tube drainage system, and it allows the content to come out efficiently without much strains. So let's talk more about the chest tube drainage system. How is it set up? What type of chest tube drainage system do we have? And how do we manage either of them? So like you said, the drainage is facilitated by gravity, and apart from gravity, we have the positive pressure and we have the sanctioning as part of the principles guiding the drainage system. So however, the drainage system is categorized into three types, and we have the first type that we talk about, the single bottle water seal system. And in the single bottle water system, we say this system has only the collection bottle or the drainage collection bottle, and the drainage collection bottle is covered by a layer of water. So this will permit drainage of air and fluid from the pleural space, but does not allow air to move back into the chest. So in the single bottle water seal system, we will have the tube that is connecting to our patient and it's draining the content into this bottle, but this bottle will only be a single bottle. You will only have the bottle number one, which we are calling the collection bottle. So the fluid will flow out into this bottle, or the air will be bubbling out into this bottle, which we are saying it usually has some layer of water before the other contents comes in. So because it has a layer of water, if it is air, they'll be bubbling here. If it is blood, it will basically discolor the water and the content will keep increasing. But then we have the second system that we'll talk about, the two bottle water seal system. So the two bottle water seal system consists of the water seal chamber and the fluid collection bottle. So the two bottle water system will have bottle number one on this diagram and bottle number two. So bottle number one, we're talking about the collection drainage bottle. Well, bottle number two, we are calling it the water seal bottle. So this bottle will have water, but this will be the collection bottle. So if it is air, it will be bubbling out. If it is any other fluid, it will be flowing out here. But then we have the three bottle water seal system. This one is similar to all the aspects of the two bottle system, except that we shall add a third bottle, and the third bottle is purposefully put for the purpose of controlling sanction, or to control the amount of sanctioning that will be taking place in the water seal system. So we'll have three bottles. So we'll have the drainage collection bottle, the water seal bottle, and the sanction bottle. So the sanctioning bottle is to create a sanctioning effect to pull out the contents and it comes out. So that's how these systems are set. You can have the single, you can have the two bottle water seal, or you can have the three bottle water seals. Currently, I think we have a lot of the single bottle water seals being used as compared to the three bottle water seals. But all these are the different systems that the client can use, or they're available for use for the chest tube drainage system. So here are the various displays of the bottle system. So we talked about the single, the two bottle water system, and the three bottle water system. So the single bottle water system, we said it has the drainage bottle, which is having water, and the content will be flowing into this bottle. But the two the two bottle drainage system has two systems where we have the drainage bottle and the water seal bottle. And then we have the third or the three bottle water seal system where we have the drainage, the water seal bottle, and the suctioning bottle. So that's how these systems are set. And so we may now ask ourselves, what can we do to manage the chest tube? So we have what to talk about the nursing care management of a chest tube. And the first priority management you need to know is how to monitor the fluid drainage and evacuations. So in the monitoring of the fluid drainage and evacuation is learning how much should be drained in a particular period of time. And so we are told per hour you can have 50 to 200 mils of fluid being drained immediately after the postoperative procedure is complete, or after the surgery is complete or the surgical intervention is complete. And so with this, if you're having the mediastinal chest tube, that is, you can have roughly 500 mils, or you can have even a whole liter given in a period of a day. However, in the first 3 hours of insertion, you can anticipate at least 300 mils after insertion. That is at 300 mils of drainage of fluid after insertion. But again, as you keep on monitoring after 24 hours, the fluid amount is supposed to reduce, and you can have more of like 1 liter to 1.2 liters of fluids if you're draining. That is after 24 hours. And this amount will keep becoming more serous and more less as the drainage keeps on. But the large amount of fluids are drained in the first 24 hours. And in the first hour, depending on how much amount of fluid the person has in the pleural space, the fluid can range from 50 to 200 mils per hour. That can actually give you almost, I don't know how many liters will this be, almost 40 liters in a day. So it basically depends with how much fluid is in the space and how is the flow rate. But the flow rate basically can be 50 per hour. And so if you take 50 mils multiplied by 24 hours on the list, you can have 1.2 liters on the list. But if you have 200 mils per hour, you multiply that by 24 hours, then you can have 4.8 liters of fluid being drained in a day. So basically what we are saying is depending on the amount, you can have different amount of fluids. So if on the list, you can have 1.2 liters to 1 liter of fluid in a day, or you can have all the way to 5 liters in a day, depending on the fluid flow that is coming out. But this amount will keep on becoming less and less as the client is progressing. The other bit is learning how to monitor the suction chambers. So with the suction chambers, in the suction chamber, if you have the continuous bubbling, then it means that there's normal functions. However, if you observe in the water seal chamber that there's continuous air bubbling, that means there's an air leak. And if there is absence of tidling, it means either there could be an issue with blockage or there's the possibility that the lung has re-expanded. So it depends on the different aspects. And in the water seal, you'll be observing differently. And in the suction chamber, we'll also be observing different aspects. So in the suction chamber, the bubbling means normal functionalities. But in the water seal chamber, the bubbling means there's an air leak. So however, if you don't observe any tidling in the water seal, basically means there's a blockage that could be happening or there's a lung expansion that has already happened. But other bits you need to observe is make sure that the client doesn't sleep on the tube or doesn't sleep on the tubing, because sleeping on the tubing or lying on the tubing can cause loops or it can cause kinking of the tube. So you don't sleep on the tube. It may cause, because of those kinking, it can affect the flow or patency of that tube. And the other aspect is checking on the patient status and encouraging exercises in terms of deep breathing exercises and shoulder range of motions. This is to simply allow the tube to be in place and to encourage more pressure to push the content out of the pleural spaces. But the other requirement is do not elevate the drainage system above the level of the chest or above the chest levels. Do not also strip or milk the tube. It's not allowed. And it's responsible that you maintain aseptic technique when changing the dressing. This is for the purpose of preventing infection and ensuring that that tube is free from any form of sepsis or any form of bacterial infections. You are allowed to clamp the tube only for special procedures, like if you need to change a dressing, if you're worrying about air leaks, or before removal of the chest tube. So do not clamp the chest tube if the tube is still in use. So the other bit is, what if the drainage system is broken or if the system breaks? So if the system breaks, you're required to place the distal end of the tube in sterile water containers, at least at 2 centimeter levels. And the other bit is, once postoperatively, immediately you have secured the chest tube into the pleural space, it's important that you perform a chest tube X-ray to confirm the correct chest tube placement and to see if there's any re-expansion of the lungs. But also it's key to assess for any bleeding, to assess for any infections, any leakage of air and any fluid around this tube. So it's very key that as a nurse on your side, you know how to assess and monitor the chest tube system from proper positioning, that you don't elevate it above the chest levels, you don't clamp it unnecessarily, you participate in aseptic techniques, avoid breakages, and if it happens, you know how to place it in sterile water containers. And basically, how do you know that the chest tube is working? The bubbling, the suctioning chambers, and the water seal chambers, how do you differently manage these chambers? And this is the bit where we talk about nursing diagnosis for a client who is on a chest tube. And one of the nursing diagnoses you can have is knowledge deficit related to the chest tube in terms of its indicators, contraindications, and even management and complications. You can have also issues of anxiety related to the presence of the chest tube. There's aspect of impaired mobility related to pain that is at the chest tube insertion site. And then there's impaired skin integrity related to the injury or related to the incision that has been made via the chest tube insertion area. Then we have risk for infections, which is relating to the invasive procedures. Other nursing diagnosis comes in as risk for ineffective breathing pattern related to collapsed lung and malfunctions of the chest tubes. And then we have impaired gaseous exchange related to issues of air and fluid accumulation in the pleural space. And the other bit is ineffective airway clearance that is related to the incisional pains. So this nursing diagnosis for a patient on the chest tube is broad and there are very many, so you cannot miss one to just describe your patient. From knowledge deficit, anxiety, impaired mobility, impaired skin integrities, risk for infections, risk for ineffective breathing pattern, impaired gaseous exchange, all the way to the infective airway clearance. So all these are nursing diagnoses that you can literally implement if you are looking for different approaches for managing the chest tube insertion areas. And the other bit is understanding the removal of the chest tube. When are we allowed to remove the chest tube? So removal of the chest tube should be indicated when the full drainage has ceased or the fluid drainage has stopped, like you're sure the fluid has completely come out, and when you're sure that the lung has actually re-expanded. So two major indications: fluid drainage has stopped and lung has re-expanded. That's the best indications for removal of the chest tube. So what is the role, or how do we participate in the removal of the chest tube? So number one is, when the removal of the chest tube has taken place, monitor for tension pneumothorax, that is, monitor that there's no further air leakage that is happening through the lung surfaces, and then learn to instruct the patient to do a Valsalva maneuver as the chest tube is being removed. And if you still don't know how a Valsalva maneuver is done, this is how it is demonstrated or as in this diagram. So the first step in Valsalva maneuver, the client will take a deep breath and pinch their nostrils with their fingers. So you take a deep breath and then pinch the nostrils with your fingers. Then in the second bit, after taking the deep breath and closing the nostrils with the fingers, you're supposed to close the mouth. Close the mouth. Then after closing the mouth, you should now try as if you are blowing the air out of your nose to create the air pressure or to regulate the air pressure. So when you do that, you are enabling the tube to come out easily. So the easiest way to describe this is, take a deep breath and then pinch the nostrils after you've taken the deep breath. Then close your mouth. After you've done those two, you've taken a deep breath, pinch the nose and close the mouth. The second bit now is to try as if you're blowing the air out of your nose to help you regulate the air pressure. Now, when you're doing this, basically that's it on Valsalva maneuver, but the aspect of helping with that is to allow you remove the chest tube easily or to pull the chest tube easily. So that's what the patient should do when you're instructing them on chest tube removal on Valsalva maneuvers. Then after removing the chest tube, you need to apply airtight dressing to the incision site so that there's no re-entry of air into the pleural space. So do an airtight dressing, then observe for any form of drainage and reinforce if it is necessary. But the last bit you need to know is to observe for respiratory distress and any further pneumothorax cases. So remember, you're removing a tube from the chest, and this tube automatically will create an air entry space there. So what happens is dress it with airtight materials or dressings, observe that there's any further drainages or reinforce it if necessary, and then observe for any respiratory distress or pneumothorax. But the purpose of removal is you have confirmed that the lungs have re-expanded and the drainage has ceased. So there's no more air coming out and there's no fluid coming out. So you want to monitor for further pneumothorax, you want to instruct the client to do Valsalva maneuvers, do an airtight dressing, and reinforce it if it's necessary. And lastly, what are the possible complications of chest tube? So in the complications, you can have malposition of the tube, you can have re-expansion pulmonary edema, there's cases of infection, pneumonia, and also frozen shoulders. So if we are doing chest tube management, you need to watch out for any of this. All the way from malposition, which is very key, the malpositioning, the pulmonary edema, infections, pneumonia, and even the frozen shoulders. So check for the complications and manage them appropriately. So thank you very much for staying with me all the way to the end. As I always advise, don't forget to subscribe, like, comment, or share. Till we meet again, bye-bye.